All right. So again, welcome everybody. My name is Marissa. I am Clinical Director for Children with Diabetes, and I have the privilege of introducing tonight two of our esteemed CWD board members, George Huntley and Stewart Perry. And they are kicking us off on our advocacy night for Fall Friends for Life 21. And I will go ahead and let them take it away.
Well, good evening, everyone. I'm going to share my, you've disabled it again.
Ooh, let me fix it.
I can't share my screen. So it's all a secret, but it's a pleasure to be with you. I will try this again. Look at that. The technology is astonishing.
Okay, George, Marissa took 2 of our minutes, so we have 2 extra.
Very good. Very good. I think so. So diabetes advocacy in the U.S. That is what we're here to talk about. And I am George Huntley, and Stewart isn't.
Correct. I'm not George.
So I'm a longtime volunteer with the Children with Diabetes. I'm the treasurer. I'm on the board of Children with Diabetes. I'm also the CEO of the Diabetes Leadership Council and the Diabetes Patient Advocacy Coalition, which we'll talk a little bit about today. I'm a patient with type 1, been living with it for 38 years, have 3 other family members with type 1, have a little bit of type 2 in the family. And the only other thing I will mention is in my day job, I am the chief operating officer of a professional services firm. And in that role, I have been the plan administrator of a self-insured health plan for over 2 decades. So I have that payor perspective as we get into advocacy in this conversation today, as well as the patient and the person who's paying for it. So with that, my friend Stewart, please share some pearls of wisdom about yourself.
Well, I think, George, that my name is Stewart Perry. I own an insurance agency, a State Farm insurance agency in Lexington, Kentucky. I serve on the board of all 3 of these organizations in the center. And like George, I was former national chair of the board of the American Diabetes Association. I've had type 2 diabetes for over 30 years. And none of you came to listen to me talk about myself. So George, let's go to the next slide.
That sounds like a plan. All right, so we're going to do diabetes advocacy in 60 minutes or less. Since we had 2 minutes already taken from us, we're going to get through this. And we're going to just kind of go through Advocacy 101. We're going to talk about what the problem is. We're going to talk about rising costs of diabetes, which in fact is part of the problem, but not all about it. And then most tangibly, we're going to talk about what you can do about it. So let's dive in.
So advocacy, let me read to you like you're in 3rd grade. Advocacy requires the combination of facts and passionate stories amplified by a community speaking with one voice. And that is probably the last 2 words are the most important part of this slide. And that is that all of us need to be talking with one voice about what's going on in diabetes. So, George?
So advocacy is about hearts and minds. It's about creating a lasting impression at the right time. So this is about getting the combination of the stories that change your hearts and the stats and the facts that change your minds. You've got to have both of those things together. So you can get a medical expert, a technical expert out there, but they don't actually impel change or inspire change in the legislator that we're trying to get to. We've got to put a human face to it, and that's really where advocates come into play, so that we make this real. And hopefully by the end of this hour, you'll realize how very important it is that there's a face to diabetes and a face to these issues. So, we're going to talk about what your advocacy superpower is. And I thought that they did a really good job of getting my profile in this graphic, but Stewart, they got yours wrong.
I would say so, George. Thank you.
Just a little bit. Is your superpower speaking? Are you a good orator? Are you a good writer? Are you better at writing than speaking? Are you a good organizer, researcher? You good at training others? Are you in the social media aspect? Do you do community building? Is that something? There's a lot of ways that you can amplify what you're good at through advocacy. There's any number of ways.
Thank you for putting me down at the bottom with the question mark. So as George just said, what is your superpower? So in this case, there's a room and a role for everybody. Social media, posting, commenting, making a phone call, letters, op-eds, volunteering, going to a meeting and listening and sharing what you heard. Grassroots advocacy, fundraising, testifying, or running for office. I did that one time. I made that mistake, not going to make it again. So you've got to ask yourself, where are you the most confident? Where can you stretch a little bit? You've heard about stretch goals. What do you enjoy? And what makes the most impact? So I think the point of this whole slide is, George, that everybody can get involved where your comfort level lies.
Yeah, and we'll show you how.
So, George, let's talk about this for a second. What is the problem? We're talking about diabetes. What's the problem?
Well, the problem is a lot of us have it and it's really expensive. So it's right now 1 in 8 adults. So it used to be, we gave this presentation a year and a half, 2 years ago, it was 1 in 10. Now it's 1 in 8. 34 million Americans have it. It's 1 in 4 healthcare dollars 4 years ago. You know, it's at least that or more now. The dollars are probably just bigger. Top 4 healthcare derived. This one here, crunch time. The Medicare and Medicaid, they pay 67% of the cost of diabetes is paid by the government. And 60% of that spend is spent on complications versus the management. So we're not investing our healthcare dollars wisely. And we're not very healthy by the time we get to Medicare. So we've got a lot of issues here. It's just expensive.
So George, talk about COVID. You know, that's the big driver right now. People with diabetes and COVID?
People and diabetes, they go hand in hand, unfortunately. It's tragically. So we learned through COVID. Now, COVID's been tragic because 40% of the COVID deaths, and there were over 600,000 of them, were people with diabetes. 40% of that list. So we lost a lot of people in our community due to COVID. 6 times more likely to be hospitalized, 12 times more likely to die. And as horrible as that is, as an advocate, we need to take that information and make that part of this dialogue so that the importance of it, the impact of it gets to the legislators.
And you know, George, that's one of the reasons that DPAC, DLC, CWD, and a lot of other organizations pushed for immunizations. People with diabetes were not included in that first round, and that was just wrong.
Yeah, that's right. And DPAC wound up sending a couple thousand letters to governors across the country trying to get diabetes as a chronic disease, as a something that got you ahead in the line. It turned out not to be all that critical, but we have to advocate.
Right.
So Stewart, it's really not fair the way things happen here. Talk us about that.
You're right, Georgia. And, it is truly unfortunate that communities of color are affected by diabetes much more than non-Hispanic, white America and the world. And the inequities are there not just in the incidence of diabetes, but in the access. The most important thing on this slide is that blue bottom right-hand corner where it says access to current standards of care. That's where communities of color are getting nailed, and that's just wrong. And we do now, and we continue to advocate that everybody should be treated equal, no matter race, creed, sex, social economic standard, any of that. Everybody should have access to the health care they need to manage their disease or prevent their disease.
As a quick example, guys, when CGMs were first introduced into Medicare, over 90% of the recipients were white. And there's so many other examples systemically where these things happen. We've got a lot of work to do in this regard.
It's just wrong, George. It's just wrong.
It really is.
But there's room for improvement, right?
Yes, there is, because we're really bad. I mean, these are horrible statistics. There's 34 million Americans with diabetes, and there are 16 million ER visits every year. That's insane. There's almost 8 million inpatient hospital stays every year. We're not doing a good job of treating the disease. So 16 million is almost half of them. about half of us, only about half of us, reach our A1C goal. And that, I've seen stats that said we're more likely reality in the 20s, reaching the A1C goals. Only 20%, not even, meet the A1C, blood pressure, cholesterol, and non-smoking goals, which means our money is, our healthcare spend is going up in smoke. We're spending all this money because patients are not getting the care they need, and 89% are overweight or obese.
So, okay. So George, we can go to the next slide. So this is a slide people have seen before. Let's talk about the elephant in the room. We've talked around a whole lot of things, but George, let's talk about rising costs. That's an issue.
That is absolutely an issue. So Stewart, where is all the cost coming from?
Well, you know, George, if you look at this slide and you see over on the right where everybody's pointing fingers the other way, everybody has a part to play in the rising cost of healthcare and drugs. The manufacturers, the insurance companies, the pharmacies, the policymakers, the hospitals and health systems, the employer and plan sponsors. Now, insurance companies, employer and plan sponsors are about the same, are many times one and the same. The patients and the advocates, that's us. We've got to stand up and ask about healthcare costs. We shop cars, we shop insurance. We certainly should shop healthcare costs. And then I left your favorite, George, to the very end. PBMs, pharmacy benefit managers, who control 87% of the prescriptions that are filled in the United States of America. All these people have a part to play. We're not here to defend any one of them, except, of course, the patient. What we're here to do is show you what's going on in our healthcare system now.
Yeah. And this gives us a list. When you think about advocacy, back to where's your superpower, how are we going to, we have to advocate to a whole host of players. It's not just policymakers. It's not just Congress. It's not just your state legislators. We have to advocate with all of these organizations, or we're not going to get the job done.
But at the end of the day, George, the bottom right-hand corner, that's who ends up footing the bill.
Yep.
So let's talk about that a little more, George.
So patients are paying more while the prices are going down. So insulin, and these dollars that you see up here, there's not a footnote. This is me buying insulin in February of this year in Indianapolis, Indiana. The list price is $334 when I purchased it. This was rapid acting insulin for my pump. The net price was $85. Now, my plan passes through rebates, which we're going to talk about, but many plans don't. In fact, a lot. That's why you people are yelling at. But the net price is dropping because competition is rising. We've got a couple of brands. We've got biosimilars in the insulins that we're taking. We've got now a interchangeable biosimilar. There's more and more insulins coming in, and we're going to talk about the good and the bad of that. More and more insulins coming in. Competition's rising. Prices typically drop. That's how free market economy works, except for drugs.
But George, I thought they made insulin in Indianapolis. You don't get a discount?
You know, it should have saved on shipping. I mean, come on.
You would think so.
Yeah, I really should have been.
So George, this is irritating to say it the least way. So the system is flawed. What's the system look like that does this to you?
It's perfectly understandable.
I love this slide. All right, now I'm going to try to explain this slide. So everybody that's watching this, put your left hand over the left-hand side of the screen. So we'll talk about that in a minute. Anybody ever heard that drugs are cheaper in Canada or Mexico? This slide illustrates exactly why. Up here at the top is the consumer. That's us. That's the patient. We go to the pharmacy, and this of course works for any drug, but we're talking about insulin, right, George?
Yep.
So you go to the pharmacy, you give them your script, or you get a refill, and you say, I need my insulin. The pharmacy says, okay, we just got a shipment from the drug company. down there at the back. You pay your deductible or your copay. Or if you have no insurance, you pay the list price right there, George. Isn't that correct?
That's correct. Yeah.
So then you take your insulin and you leave, right? Then all the other stuff comes in. Over on the right is the drug wholesaler. And the drug wholesaler gets a piece of that vial of insulin price. Down at the bottom is the drug company. They're the people that deliver the vial of insulin and get paid for the vial of insulin. So that's the way it ought to work. That's the way it works in other countries. But now, George, unfortunately, I flunked 3rd, 4th, and 7th grade math, and you're a CPA. Try to explain to me the left side of this screen, will you please?
I'll do my best. So it is inexplicable, but the pharmacy, the drug company is taking a portion of the money that they have made for selling the drug, and they are giving that to the pharmacy benefit manager as an access fee to the formulary. The pharmacy benefit manager, this player here is the one that creates and sets the formulary on all the drug plans. So they decide which insulin that you get access to. They decide which SGLT2, GLP-1, whatever drug you're on, they decide, and you typically get one in that class.
That's that big list that tells me what drugs I can have and what I can't, right?
That's exactly right. So the drug company's paying money to the PBM to get on that list, because if they don't get on the list, they can't sell their drug. So it's an access fee. Now the PBM is paying a little bit of money to the pharmacy. Pharmacy is actually giving them some money too, which this doesn't really show that. The pharmacy benefit manager then is giving money back to the insurance company and the health plan. As an employer, I'm the health plan. So this is my company up here. So of the money that goes back to, I'm going to go back to the slide before, when you say you're at 334 and the net was 85, 334 came down from the consumer and the drug company only kept 85. Only, we can have a conversation about that, but they kept 85. The balance of it went over to the pharmacy benefit manager, who keeps a slice and sends the balance up to, and most of it, frankly, up to the insurance company and the employer. From an insurance company standpoint and the employer standpoint, it's I'll call it funny money. It's money that is not well accounted for. So you can put this in your slush fund. You can do whatever you want with it. But what they claim they're doing is they're keeping the cost of your premiums down.
Oh, yeah, right. Sure. Mine goes down every year. You know, I just re-signed up in November for my plan for next year, and it certainly went down not. And George, now wait a minute. So this is called a rebate, correct?
That's a rebate. That is correct.
It's called a rebate, correct? Which is different than the rebate I get when I go buy a car.
Well, the difference is when you buy a car and they give you a rebate, you get the rebate. In this instance, the rebate goes to somebody else, not you, but you still bought the whole car.
It goes to the insurance company and the PBM, correct?
Correct. But you still bought the entire car.
Okay. But so do we know how much all this is, George? I mean, it sounds to me like there's a complete lack of.
There is a complete lack of transparency within this, but we do know, and I'm going to shift this down, we do know from reports to Congress by the drug companies what this has looked like over time. So if you look at the cost of insulin, the list price versus the net price over from 2012 to 2020, so this is pretty recent information, list price has gone up 141%. This is actually Lantus. This is Sanofi's Lantus. Net price dropped 53%. So the cost that the company got, and I'm not here to protect the company, but we are here to say the driver of the massive growth is happening by all the middlemen in between. And that's that's the piece of the pie we've got to really attack as advocates.
George, I mean, I'm trying to follow this slide. You're talking about a difference between like $334 and less than $100. So there's over $100 and some odd dollars.
There's over $200.
Over $200 that Sanofi in this case pays back.
Yep. So over $200 is going back over here to the pharmacy benefit manager, and they're probably keeping 20 bucks of that and moving it back up to the insurance company who's getting about 180. Now, there are other players along the way that are getting a piece of it. They actually touched the drug at least. But yeah, there's the money that's going up here is crazy. And they are, again, not passing it on to the consumer. If they passed it on to the consumer, I don't really care if you want to play all these games behind the scenes, just don't hurt the patient.
But George, it's my money. I feel like that movie with Tom Cruise in it, Show Me the Money. It's my money, okay? And why should the insurance, I'm already paying them premiums, why should the insurance company get to keep it?
And you're exact, that is precisely what's happening is you should get the benefit of the price that was negotiated for the plan. You get that discount at the doctor's office. If you have go to the hospital, you get lab work, anything else in a health plan, you're getting the benefit of the whatever your Insignia, your Anthem, Blue Cross Blue Shield. It doesn't matter. You're going to get their network discounts, but on the pharmacy side, you're not, unless the plan is designed that you do. And so you wind up with a scenario where, okay, well, we're going to keep the premiums down. So you've got the sick subsidizing the healthy. And that is not how insurance is supposed to work.
I certainly don't want to take my blood pressure after you and I look at these slides and talk through this. So it's an inherently broken system. Is that am I correct? Yeah. I mean, the system is not designed to help the consumer.
It is not. It's designed to save money for the insurance company. And in reality, it is not even doing that in all cases.
And they need it because they've got those 25-story buildings in downtown Chicago and every place. Yeah, they need the money badly, you know. Lord have mercy. George, it sounds to me like that, you know, we talked about one voice earlier. It sounds to me like that all the diabetes groups ought to get together and come up with something that they can show Congress and state legislators and everybody else what needs to be done to fix this healthcare system that's so broken.
Well, that's a really good idea. And the good news is we did it.
Oh, thank you. We appreciate it.
So, and you were part of it, my friend. So in 2020, we worked on a consensus statement on U.S. healthcare reform specifically for people with diabetes. So the Diabetes Leadership Council and DPAC worked together with 12 national diabetes organizations. You can see them listed here. CWD was part of this effort, and creating a list of tangible actions for Congress to take to improve care and coverage for people with diabetes, but at the same time, lower the cost for the government so that we can stop paying 60% of the money for complications. Managing this disease is infinitely cheaper than paying for the heart attack, stroke, end-stage renal care, and amputations.
So, George, you've got at the bottom of the screen to download it. Are you recommending that people download this and then share this with their member of Congress or their state legislator or whoever else is talking about this?
Anybody they can share it with. So please do download this from the diabetesleadership.org site, and please share it with anybody that you can think of, including your legislators as you're having this. You get into these advocacy pieces in this community. This is another leave behind that is it's got 30 pages of material. It is really, really good, meaty stuff.
So George, we started this conversation to talk about what's going on. So what's going on right now inside the Beltway on Capitol Hill? What in the world is happening?
A lot is fine. So now that we've turned the corner from the infrastructure bill to now working on, they're still calling it the Build Back Better, but this is really the bill that has more of the social aspects of things on it. And the items on this page are things that are in the works in Congress, but they're not new laws. They're not done. They're not, so anything that we're going to talk about on this slide, which is some amazingly exciting things are on this slide. This is, I'm actually stunned to be able to talk about this. But it's not real until we as advocates get it over the finish line and Congress does their job and we get this done. So it's a gelatinous blob.
But as I understand it, this is what you're showing on your slide is a mixture of the proposals that are up there, right? Some of them are White House, some of them are congressional. This is a mixture. Am I correct?
Yes. So we've got the first several pieces of this are part of this. It's a combination. There's the Build Back Better bill, it's a House Bill 5376. There's a Rules Committee version of this that has other pieces in it. The White House has a framework for it. But the important parts in here is it addresses first dollar coverage for insulin, bypassing the deductible. And yes, and as should be applauding, everybody should be applauding, it's got a $35 copay cap on insulin. Now, that's for both Medicare and your ERISA plans. This is the holy grail.
Okay, now wait a minute, George, let me stop you right there, because you're a CPA and you're talking CPA language again, okay? ERISA plans mean federally governed plans that employers. So if you get your insurance from an employer, ERISA is what your plan is, correct?
That is correct.
Very important. Exchanges or anything like that. This is an employer-based health plan. And that's what we've never been able to crack before, correct?
Yeah, this truly takes an act of Congress, but this is because employers cover almost half of the country. Half of America get their health coverage from employers, and another 25+%, don't quote me on that specifically, get their coverage from Medicare. So getting an insulin copay cap on these two groups is enormous. And then saying, oh, by the way, it also has to bypass deductible, meaning you're getting first dollar coverage. You're going to go, if this passes, and the current language says January 1 of 2023, this would mean that you don't ever pay $300 for a vial. You would pay $35 for your insulin for each prescription. So if you take if you take a short acting and a long acting, you'd pay $70. It would be per prescription, $35, $70 again if you're taking more than one different kind, and you could never be faced with a bill at the pharmacy which has a comma or which is high three figures. All that nonsense that's really crippling a lot of people would really end with the enactment of this. It does not address, go ahead, it does not address states, and it does not address the uninsured.
But George, to be fair, DLC, DPAC, and CWD have all said there should be no copay, no co-insurance, and no deductible on insulin and other diabetes supplies and medications, because they are just as much preventative as a flu shot or a mammogram or anything else. Is that not correct?
That is correct. We would support, we advocate, you can save money by giving insulin away. You truly can in a health plan, but we'll take the win at $35. The only other thing I want to share here is when this goes in, this is going to be like any other formula. You're going to get one short acting insulin, one long acting insulin, but we'll take it at $35. That's going to save a lot of lives. It's going to save a lot of lives.
So George, and I see 2,000 out of pocket on Medicare Part D, which is the drug part, correct?
Yes.
Why should people that are on this call that are 35 years old or 45 years old care about Medicare?
Well, assuming we live another couple decades, this is going to impact you eventually. So number one, there's that. This is gonna, I'm closer to it than perhaps some of the folks on this call are.
I'm closer to it than you are. So go ahead.
Yeah, there we go. The other piece of this is when Medicare does something, commercial insurance, the employer plans, the ERISA plans very often follow. Now, many of these plans have high deductible health plans, and 2000 is actually cheap. But in a Medicare plan, this piece is good news for people with diabetes. This actually is good news for cancer patients, arthritis patients, anybody who is on a drug that is has a super high cost. Now you're capped at $2,000 and you get coverage, and it's going to go a long way to reducing the medical bankruptcies of our seniors. So we should all be very excited by this and very much for it.
So George, it talks about direct negotiations with manufacturers, but that doesn't sound like it says insurance companies or PBMs or pharmacies or anybody like that.
Yeah, that's correct.
So they're talking about trying to reduce one part of the puzzle, not all parts of the puzzle.
So it's interesting. I'm going to take us back to our hairball. Because basically they're saying the government is they're going to cut out this and they're going to negotiate directly with the drug company. So the first thing to understand is today in Medicare, and this is all Medicare, guys, but today in Medicare, this is how Medicare works. All of them, you're buying Medicare Part D, you're in a plan, and you're going through an insurance plan for Part D, and there's a pharmacy benefit manager managing those formularies. That pharmacy benefit manager, the government is the player up here. So this is the government up here. They're getting the benefit of all the rebates. They're getting the benefit of all of the negotiations that have occurred so far. They're not passing the rebates on to the consumer, which they need to. But that's the important thing to understand, is that the government is already negotiating on behalf, having been negotiated. So this proposal would put the government in this spot. So that's the first thing to understand. So this could be very good. This could be very good and lower cost, etc. Yeah. Here's where we should be a little bit concerned. And until it's fleshed out, we don't know. But here's where you'll see concern coming out. Now you've got the government being the pharmacy benefit manager. The government isn't necessarily good at doing that. A few years back, and I think this was the foundation of DPAC, Stewart, you can share more on this. A few years back, the government decided to negotiate and do competitive bidding on glucose meters. Yeah. And what was the result of that?
The result of that was very simple. We got inferior strips, inferior meters. We had people getting their blood sugars incorrectly measured. But we saved money. And that's all that matters, George. That's the problem with the system we have right now. So DPAC got involved in the competitive bidding because people were not getting what they needed. We were hearing horror stories of people who thought their blood sugar was good and it was 100 points different. Or the strips that came didn't even work. They threw bottles after bottles of strips away. So, and the meters themselves, everybody knows before CGMs, everybody pricked their finger. I still do that. Prick their finger and check their blood sugar. And one meter to the other can have a difference in your blood sugars. Correct, George?
That's exactly right.
But there's a certain amount that's allowable. These meters, it was just out there. So I'm from the government. I'm here to help. Army intelligence, all those things we talk about that are misnomers. I'm not sure we want to put the government in that position. This, once again, it just talks about manufacturers. I mean, you need to negotiate with everybody else. And I realize we're talking about Medicare. And the reason that we care about Medicare is because when Medicare does something, private insurers tend to follow.
So one of the concerns is back to that CMS competitive bidding, and to really make this into a drug scenario. All right, they limited choice down to one Chinese knockoff. The American companies largely started getting out of the business, stopped investing in the business, which we do not want. Certainly don't want that in insulin. The quality of the product, to Stewart's point, they were getting really bad readings. And we have many research projects were done that were sent to CMS to show how many seniors stopped getting access to care, and actually did analysis on how many people actually died as a result of that program. So that's the far, extreme category of this, which the government has proven capable of doing within the last decade. One of the other concerns on this, back to you get access to one drug, I'm hoping that drug is not something made in Asia that is not set up to the same quality standards that would have been on here, because there's a lot of issues around that. So when we talk about that negotiation, we want to make sure that we get access to the drugs that we need, that they're the same quality. The other thing we have to be concerned about is what's going on in the marketplace. And so I want to just touch on for a moment, because these things don't get a lot of press. Within the last 5 years, as we talk about what's going on with the net price of insulin, if you are the CFO and the senior management of a company that is seeing their number down, again, it still may be too high, but if you're watching that go down, you are not going to invest further in that market because it's a declining revenue stream. Merck, within the last 5 years, had an insulin that they paid $150 million to get into. And excuse me, they had an insulin ready to go. They paid $150 in penalty with their partner to not bring the insulin to market. They spent $150 million to not get into this mess because they didn't think they could make money. Sanofi has abandoned all research with regard to diabetes. They've abandoned the diabetes. Lantus is still on the market, but they're not coming out with the next Lantus. They're out of the business. As patients, we have to be concerned that there will continue to be a pipeline of new insulins, smart insulins, glucose sensing insulins, insulins that you take once a week. These things have to hit the market, or we're going to wind up not getting where we need to go. So there's a lot to be said here.
What they taught me when I first started advocating for research dollars is the government does cure research, and manufacturers and others tend to do research into care research.
Yeah.
So they want to improve insulins, improve medications, but the government does cure research. Is that correct?
That's right. The NIH funds the cure research, and you're right. Getting something to market that's going to help a patient move forward. And where does that money get invested? Which disease state? Diabetes has a lot of patients, but the market channel needs to be open. So this may not become an issue, depends upon how this gets implemented. It's something that everybody should be aware of. Right. I'm not saying it's good or it's bad. I'm saying that there are risks to this scenario that isn't obvious.
We've been stuck on this for a little while. So let's go on to biosimilars. Aren't biosimilars the answer?
Well, they're a help. Okay, so biosimilars bring it's not quite a generic. It's the closest thing you're going to get to a generic in a drug like insulin. And you get, with the biosimilar, a lower price, typically. Now, a couple of problems with that, which is why HR 2846 exists. Over the last 10 years, the numbers of generic drugs that were on the generic formularies, the generic tier. So if you're in your formula, you're doing your copay, the generic is the lowest. They want to drive you to take the generic. They want you to not take the brand name drug. That seems common sense. The numbers of generic drugs that are on the generic formulary have gone from 90-something% to less than half. So less than half of the drugs, the generics and the biosimilars, are actually on the generic tier. And it's a head scratcher until you realize that the pharmacy benefit manager doesn't make enough money off of the generic drugs and the biosimilars.
So what does this bill do?
This bill requires a biosimilar or a generic that is less than, I believe, 30% of the list price. So it has to have a level of reduction. That requires them to place that on the generic tier in a formulary and allow the patient to benefit from the lower cost. The problem is the patient, here's the biosimilar, but it's no cheaper for the patient at all. And that's not the right thing.
Okay.
You know, other examples, as Semglee just launched, the Lantus bio, the interchangeable version, they actually put out 2 versions of that drug. One has a rebate in it, has a high list price, still lower than the brand drug, and the other has a significantly lower price. And if you have no insurance, you're going to go buy that one. It's the same drug, same manufacturing plant, going to a different vial with a different label, just like Lilly has on their Humalog. They've got a Lispro version of it. Same plant, just different label on the vial. But the price is different. So, but on a formulary, you're going to find the higher price version of it because they want their piece.
Okay, so if we move on down the page.
Yep.
Copay accumulator ban. I thought copay cards were good. That's where I go and I pick up my drug and I get a card from the manufacturer that says you won't have to pay more than $25, correct?
That's correct. You're not going to pay more than $25 except.
So we're going to ban those?
Well, we're going to accept that you're not going to get credit for what the drug really cost. So here you go, you buy a drug that costs $500 and you paid $25 for it. You should get $500 worth of credit for it because you just bought a drug that was worth $500. And these copay accumulator systems, programs, they basically swipe that money back from the patient. And so you effectively pay your deductible twice because the manufacturer, the insurance company is getting the value of your deductible because you've bought these drugs and then they're stealing it from you. So you got to keep paying. And the patients are, you get 6 months into a program, your copay card runs out and now you can't afford the drug that you're now on and you really need.
So what you're telling me is on this, the manufacturers pay the difference between what the list price is and that $25 you pay. And the insurance company is not recognizing that. Is that correct?
That's correct.
Okay, why should the insurance company care who pays it? If my grandmother wants to pay it, why should they care?
They shouldn't, but they're seeing it as an opportunity to make more money.
Okay.
And that's we all know that they need more money. They're poor.
Right.
But this bill at the federal level would be a big help. And again, it's beyond just diabetes. This is a big help.
Okay. So George, I know you've got more things that you can cover very quickly. So what else is going on at the federal level?
So, there are so many different topics. We've talked a lot about how things that would directly improve patient access and care and cost. There's a lot going on in prevention as well. There's the Treatment and Reduction of Obesity Act. This is children with diabetes. It's not necessarily, germane to this particular group, but in type 2, obesity is the major driver. It is illegal in Medicare to cover a weight loss drug. So the Treatment and Reduction of Obesity Act does 2 things. It increases the number of people that can give care, such as behavioral counseling and nutritional counseling. And it also allows Medicare patients to actually get access to those drugs that now exist. Back in 2003, when Part D drug bill came into play, there weren't any out there. And the only thing out there was fen-phen. It was killing people. There's drugs there's a bill out there for expanding access to diabetes self-management training. That's certainly good for the patient. Preventing Diabetes and Medicare Act. These are bills out there that will significantly help people with diabetes. Maybe not as life-changing as $35 insulin, but there's a lot as an advocate out there. There are a lot of ways that we can get involved and support, and including obviously increase research through NIH and the special diabetes program reauthorization.
So, George, what about the state level?
We got to do all this at the state level. We have, this is through DPAC. We have a state level, we've been doing state level advocacy forums. We have a scorecard for each state. This is the state of Washington. We just did this last week. And, or it could have been this week, it was this week. Time flies when you're having fun. But we go through all of the things that a state can actually do, and we rate them on, have they done it yet? And we talk to advocates and legislators about these issues because, you know, Stewart, talk to us about what a diabetes action plan is.
Yeah, and George, and that's a great point. At the state, when the federal government is not passing laws to get things done, state legislators get you people that are listening, get you yelling at them. So they start passing laws on the state. A diabetes action plan legislation is simply a plan by the state to fight diabetes. What are you going to do for type 1 and type 2 diabetes in your state, and what resources are you going to put behind it? Diabetes caucuses, that is just basically a club. It's a club of all the state legislators that care about diabetes that get together and meet and do something. In some states like Illinois, they do a lot. Other states, they just talk. But at least talking most of the time leads to some kind of action. The insulin copay caps, we talked about that on a federal level right now, George. This is a state level. The problem is they only affect the state employee health plan and that 10% of the people that get their insurance through a state plan like the exchange. Supply cap, same scenario. Copay accumulator ban, same scenario. First dollar coverage on diabetes, rebate pass-through, all those things are only being affected to that 10% of the people. It doesn't affect the ERISA plans, which is why that federal legislation is so important. Now, Medicaid is a different issue. Medicaid is not affected by state bills, and Medicaid CGM coverage is important, George, just like Medicaid coverage for, it already has first dollar coverage on most medicines in Medicaid, but they're not covering CGM. And like you talked about obesity, they're not covering obesity drugs many times. So those things need to happen there. And then that emergency access law. Now, Indiana has that, George. Talk about that emergency access law just very quickly.
So, you know, we all know that insulin vials come in glass, the insulin comes in glass vials. You drop one, you've got a problem. You run out, your prescription has expired and you need insulin right away. This law in many states allows an emergency 30-day access. So it's a very good law. Everything on this should remind, everything we do at the federal level, a lot of it needs to also be done at the state level, because the state level plans, in order to get everybody with diabetes covered, we got to cover it at Medicare, we got to cover it ERISA, and we got to cover it the state plans. So all our work is not ever done, and there's 50 states to go through. So buckle up.
George, people look at me normally after we've done an in-person meeting. People come out and say, "How can I get involved? What can I do?" So let's talk about that for a second. DPAC has a DPAC champion. DPAC champions are people who've stood up and said, "I want to help." You sign up online, you get alerts. You can do those alerts online. We have state and federal Hill visits where we put people together and go visit our congressional leaders and our state leaders. Also, we've been doing those because of the pandemic virtually. So we have brown bag events. A brown bag event basically means you bring your own lunch and you turn on your computer and you get told about what's going on in a little more in-depth than what George and I've done, as well as policy briefings. And then of course there's social media, which anybody can do for anything. So if you go to that Diabetes Patient Advocacy Coalition website, that you can sign up to be a champion. Now, a question came in, George, while we were talking about how do I sign up as a champion for JDRF? Well, JDRF, ADA, Beyond Type 1, they all have these kinds of click advocacy and this kinds of things that you can do. I recommend signing up for all of them.
Absolutely.
Because many of the times, DPAC is going to be on one issue that ADA is going to be on another issue. So I recommend you sign up for all of them. to get this happen. Now, George, why does it matter? Why does it matter for them to get involved?
Because it makes a difference. You know, when you talk to a legislator, Stewart, now how many, when you talk to a legislator, how many calls, how many letters does it take to make an impression? You've been doing this a long time. Seven.
Seven letters is a groundswell. Okay. Seven emails is a groundswell. There's
far more than seven of us on this call, on this webinar. And so here's how it works. You're going to get the alerts, and I want to reiterate, sign up for everybody's. You know, we tend to not duplicate what other groups are doing. So JDRF and ADA cover research. You're going to get all of those alerts from them. By all means, sign up and click through. This is not a competition. This is this is not a competition. It's a community. So we want to get together and get those alerts and share one voice. And it's like Chicago voting: vote early and vote often. So this is about lather, rinse, repeat. Get the alerts, personalize the emails, send the emails, click send. Visit your elected officials if you can, especially when they're not in, if they're not in DC, they're coming back during the times when they love meeting. They really do. Tell the story in your words and do this as often as you can. That shampoo bottle that I don't need too much of, but I use a little bit of it. You know, if you read in the back the instructions always say lather, rinse, and repeat. Now, who the heck repeats? I don't have enough hair to repeat, but it's a good advice. It's good advice. So when you send these emails, you go to, you get these in whichever organization, they're going to give you the details and the meat of the letter as to what the technical issue is. So this is going to be handled for you, and they're also going to send it right to your senators or your congressmen or your state legislators. Here's the part where you need to actually take a little bit more action. You got to tell your story. There's always, in all of these, there's a spot to add your personalized message. Don't just go past that. Add your message. Your message actually means something in this. These things do get read. The hard part is when you're faced with a blank slate and a blank page. Some people get writer's block. Do you get writer's block, Stewart?
No, George, I never get writer's block because I just go in there and start typing and it just all comes out. By the way, it's halftime of the Kentucky game. We're winning by 13 points. Yeah, that's how much I love this organization. I'm missing the Kentucky basketball game.
You're really taking one for the team.
Taking one for the team. That's exactly right. So stories and stats, George, are important. I mean, yeah, it's important how many people are affected by diabetes, but it's much more important to talk about your personal story with your elected official and why it matters to you, isn't it?
Yeah, exactly. You know, what does diabetes cost you in a year? Make it personal. How many of your prescriptions got non-medically switched in January? How did it impact your diabetes management? Did you have an issue? If you had an issue, share that. How many prior authorizations or coverage appeals? How much red tape did you have to go to? How many times did you have to call? How many hours are you spending? Anything else that's impacting you, make it personal and share that frustration, share that need with them, because we've got the statistics. We need the personal story. This is your opportunity to do it. So lather, rinse, and repeat. Take this action. Read, watch, and click. Learn about the community issues. We get involved in a lot of things, and there will be a day, hopefully darn soon, where we'll do Federal Hill Days in person, and state capitol days in person. I urge everybody to get involved, but please, please, please sign up to be a DPAC advocate, as well as the other organizations, JDRF, ADA, Beyond Type 1. It is really important. Follow us on Twitter, on Facebook. You'll see on Facebook, if you follow DPAC on Facebook, you'll see every time we've got an event going on and what's happening there. And really, thank you for being part of this. Thank you for being part of the community.
See in the top left-hand corner of my screen, I have a raised hand. That's exactly what you have to do. We need everybody out there to raise their hand. At the risk of sounding old, I'm mad as heck and I'm not going to take this anymore. That's what diabetes needs. Diabetes needs people to stand up and be counted. Diabetes needs people who are like myself. As long as there's breath in my body, I'm going to advocate for people and their families that have diabetes and are affected by diabetes, because they can't, won't stand up for themselves. That's my superpower, George. I will stand up and do it. The last thing I want to leave with people before Marissa gives us the hook is never ration insulin.
Yeah.
Never, ever, ever, ever. We didn't go into it tonight. It is on the websites that you see in front of you. There are resources to help if you can't afford it. George and I work every single day to try to get lower insulin prices, to try to get lower drug prices, to get CGMs for everybody that needs them. We need you to stand up with us, but don't ever let anybody ration insulin. You can get it. You can get help. CWD, DPAC, DLC, all of those organizations, the Affordable Insulin Project, all these organizations will allow you to help get help and do what needs to be done. George, I know I get passionate about this, but diabetes is serious and it has to be taken serious. You've had diabetes how long, George?
38 years.
You've been on insulin how long, George?
38 years.
And you're doing pretty good because you take care of yourself, but more importantly, it's because you've had the resources to take care of yourself. You had the ability to take care of yourself. Not everybody gets that. And ladies and gentlemen, that is not right. In the richest, most prosperous country in the world, it is not right that people drive to Canada to get their insulin. It is not right that they ration or can't get their medications when they need it. It is not right. And we've got to change that. And it takes you to stand up to do it. Thank you for allowing me, Marissa, to get just a little passionate on this. But you know me, I get worked up, especially when I think something is not right. I'm kind of like Barney Fife. I've got one bullet in my pocket. If I see crime, I'm supposed to stop it. Okay, same thing. If I see inequities in diabetes, George has got the reins on me like an old plow horse, holding me back to keep me from knocking somebody down to make it happen. That's why George and I work so well together. George, thank you for all you do. Without your leadership, the organizations that I'm involved with would not do as near as well as they are. So thanks for all you do, George.
My pleasure. Thank you all for it's an honor to be part of this community, and it's a lot of fun. I love what CW everything is passion. And Stewart, your passion is evident every single day I work with you, and it's a pleasure. So thank you all for listening, and Marissa, thanks for hosting us.
Yes.
Marissa, back to you.
Thank you, gentlemen. Really appreciate it. And you know what? It's see something, say something, right? You see something that's not, that's not the way that it should be. It's not just, it's not fair. And, we do everything we can and use, our power, what we have to make the world better. So that was beautiful, guys. And I'd like to thank you both for spending this Friday night. And Stewart, I owe you a bourbon or a beer or something for missing your Kentucky game. Thank you. And thank you all who participated. This will be recorded and saved online. If you have some time this evening or throughout the weekend, please check out the virtual exhibit hall that our very generous sponsors have online. I will put the link into the chat. And you will also get a survey at the end of this. Please fill it out. Let us know how things went, what you'd like to see more of, what you'd like to see less of. And then just one final note, this is the last week of our 100 Years of Us campaign. We are looking for 30 more individual donations of $25 to earn a $25,000 gift. And you can check that out at cwd.is/100challenge. And then I lied, there's one more thing, which is that tonight there's an open hallway. So it's just a social area for Friends for Life to, happen like it would if we had been able to be in person. So feel free to check that out. I put the link in the chat and just socialize and meet some of your friends for life.
Thanks, Marissa.
Thank you, guys.
Everybody. Thanks, Marissa.
Have a great rest of your evening.
Okay, you too.